Everyone, this is the GLAD session 3. So we have conducted successfully 2 sessions. One is in the month of April, one is month of May. So now I request our patron, Professor Subrata Acharya, to give brief introduction about this GLAD initiative. It is his brainchild, and then we'll proceed for the events. Sir, please.
Thank you, Ashok, and very good evening, ladies and gentlemen, and welcome to this GLAD 3 sessions. And earlier you have already heard Professor Ashok Chaudhary telling about GLAD 1 and GLAD 2 sessions very successfully done, and it created a lot of interest. Congratulations to them and his efforts. And GLAD 3 session is a very interesting session, very practical session, and very common session. It is an approach to upper gastrointestinal bleeding. And all of you are aware that it is actually acute catastrophic complications of events, right, which is varied. And it kills. And it needs immediate attentions. And now with the advent of technology, you can detect the cause of the bleeding and stop it immediately. And you can, well, make them all right or resuscitate them. And now nowadays as gastroenterologists, we think nobody should die of GI bleeding. That is our slogan. Nobody should die of GI bleeding. And that is a tremendous approach. And that's the effort. And that's the discussion today. That even though it is a catastrophic problem, even though it is acute emergency, even though it is known to kill, our approach should be such that nobody should die. With that background, I will hand it over to Ashok to make it fascinating and give actually a very practical approach to management of GI bleed in day-to-day life and how to save life. Thank you very much.
Thank you, sir. So now, as we're going for this session, I just want to say the flow. So we have an elegant team of post directors, you can say. Professor A.C. Anand, who is heading at KIMS, Professor Akash Shukla, who is at KM Mumbai, and today's speaker, Professor Bhavdev Goswami. So they are the post directors for the sessions. And then we have a very elegant board of editors, and this is headed by Professor Y.K. Chawla. And we have Dr. Vikas is here, Dr. Mitra, he's here with us, Dr. Girish Kumar Pati, Dr. Rakesh Kumar Jagdish, Dr. Charles Panekli, Dr. Chetan, and Dr. So Dr. Akash is here, and sir, we have done a very much interesting fact. Akash has taken the lead on that. We have done a survey on the GI bleed common approach, how we are doing, and in between he will show the results after the discussion by Professor Goswami.
Thank you.
And then, sir, we have a case presentation by our student from some Dr. Pukhraj under the Professor Girish Pati's guidance. He is the mentor for him today. And then we have expert panelist Dr. Ravikant. He is associate professor at IGMS Patna. And Dr. Neeraj Nagaraj is senior consultant gastro at Jaipur Fortis Hospital. And Dr. Professor Mamun Al Mehta from Bangladesh. I think Professor Mamun is just joining. Welcome, Professor Mamun. He is one of the person always for the GI bleed cause in ACLF. I have seen his lot of efforts on the GI bleed. So hopefully, Professor Mamun will remain to guide us. In fact, we are all national. Professor Mamun is one of the international guests. Welcome, Dr. Mamun. And at the same time, our Professor Anand will be, I think, missing because of some personal engagements. And Dr. Akash will come for the vote of thanks. So this is the sequence of events. In that, we will request all our panelists to be involved with the questions. And I request, because the GLAD is for the general physicians, the questions should be more of practical oriented, daily use, how we can do our address change in practice. And with this, I request Dr. Goswami to take the stage for another 15 minutes to give his deliberation on the management. Thank you, sir.
Thank you, Ashok. Respected Asarji sir, Shaula sir, Ashok, then Mamun, and all my friends. Today we are going to discuss about the approach to a patient with upper GI bleed. Can you see the slides, no?
Yes, sir.
Okay. So this is the problem with upper GI bleed. It is potentially a life-threatening abdominal emergency. It is 4 times more common than lower GI bleed, and overall mortality is almost 6 to 10% of them. The causes of upper GI bleed, we have got a whole list, and mostly it is the ulcers and the esophageal varices or gastric varices. And of course, we have got the medullary tear, erosions, eosinophilic esophagitis, neoplasm, vascular ectasia, and all others. But mostly it is ulcers and varices, and my talk will be surrounding these two problems. So peptic ulcer, the facts what we have got, almost 15 to 20% of patients with peptic ulcer, they experience bleeding. Annual risk factor is 4%, and almost up to 31% of the ulcer, they bleed in the elderly and are associated with non-steroidal anti-inflammatory drug related. Coming to the variceal bleed, what we have got, the esophageal varices develop almost 50 to 60% of patients with cirrhosis. 30% of these patients will bleed within 2 years of the diagnosis, and the risk of the second bleed is almost 60 to 70% within 2 years. And up to 50% of these patients, they will die in the first bleed itself if the comorbid condition and the liver disease is very severe one. The clinical presentations of upper GI bleed, what we have got, mostly it is melena, black, tarry, or foul smelling stool, or it may be hematemesis, bloody, vomitus, or it may be also sometimes hematochezia in the form of the red, maroon, or fresh blood even. And sometimes, of course, you can present it with the lightheadedness or syncope attack. That's what the presentation. The probable source of the upper GI bleed, or GI bleed, of course, from the gut, some indicators we can see. Hematemesis, probably it is the upper GI bleed, almost certain. Probably lower GI bleed, rare cause. If it is melena, probably it is upper GI, but also possible from the lower GI bleed. Hematochezia, similarly, it is possible from the upper GI bleed, or it is also probable from the lower GI bleed. So vocal blood, of course, both way, upper GI, lower GI, it is positive. So first of all, what we should do, the most important point is the evaluation of the patient and the resuscitation of the patient immediately. So we have to decide hemodynamically stable or patient in the shock. We should evaluate. Then we require hospitalization of the patient. And number 3, whether it is upper or it is a lower GI bleed. That's what we have to decide immediately after evaluation. Then the evaluation goal, what we have got, we have to assess the severity of the bleeding, assess the identity or source of the bleeding, and also determine the conditions that may affect the subsequent management of the patient. For that matter, we need to have a good history of the patient, physical examination, laboratory tests, and even nasogastric lavage tube. So what also important in the history is the pain, any peptic ulcer history, comorbid condition, any NSAID or other medication the patient is taking, and also we have to take the history of the alcohol. The physical examination, what we should look for, it is the vital signs instability, respiratory distress, or on the patient with beta blockers. Overall appearance of the patient, the abdominal examination to rule out the peritonitis, and rectal examination also as important as for the GI bleed. So in the physical examination, if the patient has got the resting tachycardia, so it means almost mild to moderate hypovolemia, loss of the blood is less than 15%. If it is the orthostatic hypotension, the blood loss is almost 15%. And if it is the supine hypotension, that means there is huge loss of blood up to 40% of the total volume. Estimated fluid and the blood loss in shock. This is what the chart clearly shows. All of us we know about the class 1, class 2, class 3, 4, and the loss of the blood pressure, pulse, respiratory, urine output. We can assess from here how much blood loss the patient may have. Then the question about the blood volume resuscitation. What we should do? Always we should maintain the hemodynamic stability of the patient, and also at the same time we should avoid over aggressive transfusion of the blood. The hemoglobin value and the type and the cross matching is important one, and always we should look for the restrictive transfusion strategy. Already the studies clearly showed it has got the advantage where our transfusion hemoglobin level should be ultimately at 7 gram percent or near to that. But there is also other thoughts about the liberal transfusion strategy, where blood transfusion, the aim is around 9 gram percent. The effect of the number of the packed erythrocyte transfusion, the relation with the surgical need and the mortality, also it is very clear from these studies. If the number of the transfusion blood is 1 to 3, the surgical need for these patients is 6%, mortality is 14%, whereas if it is more than 5 units of the blood transfusion required, the high rate of surgical intervention, and also we have the high mortality rate. The risk stratification, always it is the clinical one. Of course, endoscopically, we should stratify, and most of the places nowadays endoscopy is available, laboratory features, and ultimately from here, we should decide. The red blood on the nasogastric level is a big question. If the patient has got the severe bleeding, there is tachycardia, the nasogastric aspiration will be red blood, and hemoglobin level will be less than 8 gram. It means severe bleeding. The initial assessment and the resuscitation, here we have got the problem, and immediately we should decide the level of the care where we should put the patient in ICU or in the general ward, depending upon the condition of the patient. And the next point will be to consider intubation for the patients with hepatic encephalopathy or severely if there is blood loss. The assessment of the patient, always we should give importance to these points: pulse, systolic blood pressure, orthostatic drop of the systolic blood pressure, oliguria, the cold extremities, and mental status of the patient. If you see here, the adverse prognostic factors we can identify from here of these points. If the age is more than 60, if there is comorbid conditions, the vital signs, if the systolic blood pressure is less than 100, pulse more than 100, stool color red or maroon, and the blood transfusion requirement 3 units or more for stabilization, it means something big. The systolic blood pressure less than 100, pulse more than 100, red maroon color of the stool means almost mortality at 20%, and the operative intervention is almost 50% of these patients. Then the upper GI bleed, we have got the nasogastric tube. The placement of the nasogastric tube can be considered because of its some prognostic value that was thought earlier. we have got the newer one, we'll discuss on that. The orogastric or nasogastric lavage may be helpful to clean the stomach of the blood and clots. Therefore, we can easily do the endoscopy and the picture will be more clear. This study long back, but it shows some significant the prognosis. For example, the nasogastric aspiration and the proportion of the patients with transfusion required or surgical requirement or the mortality. The color of the aspiration, clear color, coffee color, or red color, we have got the different ways of the surgical need, blood transfusion need, and the mortality. Another study with nasogastric aspiration plus the stool color. Then from here also we can predict the mortality of this patient from different point of view. Clear aspiration, coffee ground color of the aspiration with the brown or black red color stool, or red blood on aspiration, black, brown, or red color of the stool. We have got the high mortality of this patient. So finally, the nasogastric lavage, what is the present status? The recent consensus suggests that the nasogastric and the orogastric lavage is not helpful in patients with upper GI bleed for diagnosis, prognosis, visualization, or the therapeutic effect. It is still debatable, and we have to consider all these points. The risk assessment of the patient is clinically very useful one, because the risk for the further bleeding, the timing of the endoscopy, the time of the discharge, and the level of care, all these is important for the risk assessment of the patients with upper GI bleed. The risk stratification for ulcer, what we have got the Rockel score, and different score have got the different variables from age, shock, comorbidities, diagnosis, and also the stigmata of the recent hemorrhage. From all these points, it is clear if it is less than 3 score, it carries good prognosis, but if it is more than 8, it means there is the high risk of mortality of the patient. Then always the question comes about the upper GI endoscopy. So when to do it and why to do it? Now, first of all, the role of endoscopy is very clear. It allows the accurate identification of the source and the severity of the bleeding. Also, it helps to predict the likelihood of the rebleeding. Also, it helps to administer endotherapy with the help of the endoscopy. So there is a timing question. We have got urgent within 12 hours prior to the hemodynamic stability after admission, emergent within 24 hours of admission, and elective one within 48 hours. It is already established that those patients with early endoscopy, they have got a shorter hospital stay and reduced mortality of these patients. The forest classification from endoscopy, if you see these pictures from the ulcer, we have got the spurting bleeding, the oozing, the forest visible vessel, or we have got the adherent clot, pigment spot, or the clean based ulcer. Depending upon different position, we can predict the further bleeding. Coming back to the variceal bleeding, it is very clear now that almost 50% mortality if there is variceal bleeding in the first attack itself. And the varices and mortality depends upon the type of the liver. The SILE A, SILE B, SILE C with high mortality with SILE C cirrhosis. And who are likely to bleed? It is the North Italian Endoscopy Club has identified that modified SILE classification, size of the varix, and red well marking of the varices. SILE C cirrhosis, large varix, and the red sign, ultimately 65% risk of bleeding within 1 year. But if it is SILE A cirrhosis, small varix, no red well sign, that means the bleeding chance is only 2% in 1 year. Varices increases in the diameter progressively. This is what we have got. So no varix to small varix 7 to 8% per year. Small varix to big varix or large varix is 7 to 8% per year. That's how it increases and ultimately bleeds. And also here I am just showing one slide, two patients. And my message is not all the cirrhotics will bleed from varices only. You can see here, this patient is cirrhotic, of course. He's alcoholic for 20 years. He presented with upper GI bleed. And when we did the endoscopy, so it is very clear, large varix with red whale sign. So of course the bleeding is straightway coming from the esophageal varices. You see with this patient now, the patient is hepatitis B related cirrhosis, 48 years, upper GI bleed. But here, when we did the endoscopy, because presentation of GI bleed, we could see the small varices one, and bleeding was not coming from the esophageal varices. What happened here, this patient, same patient, when we went further on the endoscopy, and while coming back from the duodenum, we saw the big ulcer with the spot at the pre-pyloric area. This is what the sorry. That means sometimes we should not presume that all cirrhotic will always bleed from the esophageal varices. So the endoscopic risk stratification. This is another slide, important slide. The endoscopic appearance, the prevalence of what we have got, and the rebleeding chance, surgical need, and the mortality. The clean base ulcer, or if you see the active bleeding, if the patient has got the active bleeding, the rebleeding chance is 55%, surgical need is 35%, and mortality is very high with 11%, whereas if it is clean based ulcer, the rebleeding chance is less, surgical need is less, and also mortality is quite low. So endoscopic management, again, we should see here the large size of the ulcer, the large size non-bleeding visible vessel, the presence of the blood in the gastric lumen, and the ulcer location, posterior duodenal wall, or the lesser curvature ulcer. They are very difficult to ultimately control, and the chance of rebleeding is very, very high. So coming to the treatment, the principle of the management, what we have got, it is both for the GI bleed from varices or from the ulcers. To restore and maintain the hemodynamic stability, to restore and maintain the adequate oxygenation of the patient, the control of the bleeding, and to prevent the complications of the bleeding. That's what we should do. We should always look for the ABC of the resuscitation. We should identify the high risk of the patient. If it is high risk, you admit the patient immediately with IV access, get admitted in the ICU, and take care of that. But if the patient is low risk, you put the patient on IV access, admit him in general ward, and next day you can put the patient for the endoscopy. So therapeutic options, what we have got for the GI bleed. We have got the pharmacotherapy, endoscopic intervention, surgery, and intra-arterial intervention. That's what we have got. So here, the pharmacotherapy of the ulcers, what we can do. The aim is to stop the active bleeding, prevent the rebleeding, and also the mechanism is to reduce the gastric acidity, constrict the bleeding vessel. For that matter, we have got the tranexamic acid, ACE receptor antagonist, PPI, prostaglandin analogs. But about the question mark about tranexamic acid, I will discuss later. If the pH is less than 5, there is pepsin accelerates the clot lysis. But if it is pH more than 6, it is effective platelet aggregation, irreversible inactivation of the pepsin, and the optimal maintenance of the hematemesis or bleeding is achieved. Why PPI? Because it can reduce the frequency of the rebleeding, its needs of the surgery is reduced, needs for the transfusion, and also reduce the length of the hospital stay. We have got the pantoprazole with 80 milligram IV bolus and 8 milligram per hour infusion to 3 days. We have got reviprazole. Another advantage with reviprazole is 20 milligram IV 6 hourly you can give if you don't have any nursing staff to continuously monitor the patient for IV transfusion. So here 6 hourly is quite enough. Then again, the pepsin, the PPI, and the ranitidine, there is a big difference in between these two. Here we can see from this chart that continuously PPI can maintain the pH at a higher level, but after second day, third day, with the H receptor antagonist, it cannot maintain the pH properly. So that's why it is better to go for the PPI. Tranexamic acid, yes, it has got the anti-fibrinolytic agent. It inhibits activation of the plasmin, theoretically advantage in reducing the rebleeding and the mortality. But please remember there is no RCT control trial to establish its effectiveness. So that's why it is better not to use. I don't personally use it. Then again, another question about the Helicobacter pylori. Suppose the ulcer patient has got positive Helicobacter pylori. So there is a big question whether we should go for the anti-Helicobacter pylori treatment. It is advisable after the patient is discharged from the hospital, we should give the treatment to the patient against the Helicobacter pylori because ultimately the without Helicobacter treatment, the rebleeding rate is very high. If it is treatment is given, the rebleeding rate is very low. Coming to varicose bleeding, the pharmacological therapy similar to ulcer bleeding, we have got the vasoactive drugs and also the antibiotic prophylaxis. The vasoactive drugs like somatostatin, octreotide, terlipressin, all are effective one, and almost everybody knows nowadays how to use it. But the question is about the antibiotic. We should always put these patients on the antibiotic because the infection rate is very high. Also, it ultimately dampens the line of treatment in GI bleed from varices. Then endoscopic intervention, what we have got, it is successful in stopping the active bleeding. It reduces the risk of the rebleeding, reduces the blood transfusion level, and reducing hospital costs and surgical emergency is also reduced. The endoscopic therapy, what we have got the for ulcer, injection
It's
therapy,
9 o'clock.
endo clip, we have got the over the scope clip. I'm not going in detail, just I'm mentioning here for the information of our young doctors. It is always safe, effective, easy to use, and it is portable. Yes. This is what the injection therapy for this patient, for example, coming with GI bleed from the esophageal duodenal ulcer. And in the next moment, when you do the injection therapy with adrenaline, the bleeding can be stopped immediately. So similarly, when the patient has got from this endoscopic stigmata of the ulcer bleed, here you can see the endoscopic appearance with or without endoscopic therapy. With endoscopic therapy, the rebleeding rate is definitely much better than those patients without the endoscopic therapy. So if possible, we should go for pharmacological therapy at the same time. Also, you can try with the endoscopic therapy if it is available in that particular area. Then there are predictors of the rebleeding, and this study showed almost 3,800 plus patients. Here, the hypotension, the hemoglobin less than 10, fresh blood, active bleeding, ulcer size. There we have got the odd ratio. So bleeding is more in this patient for rebleeding. Coming to peripheral bleeding, we have got different models. Earlier, we used to go for even injection sclerotherapy, band ligation, and nowadays, of course, it is the easier one. Always you should go for the esophageal pharynx if somebody has got, if has got bleeding, you do the esophageal band ligation of this patient, And after 7 days, you can see the picture is completely different one when the bands are slapped off. Then we have got the problem with the gastric varices. Almost 20% of the patients with cirrhosis have got the gastric varices, and it is always more severe bleeding from esophageal, the gastric varices than the esophageal varices, and we have got a high mortality of these patients with gastric varices. Here also we use the glue injection of these patients with gastric varices, and it can be stopped immediately. But point is, this glue injection nowadays, we have got other methods as well with the US guided coil therapy glue injection that can be also used. The emerging endoscopic treatment models also we have got, just I'm mentioning in the slide, Denistan, hemostatic spray, endoscopic suturing, over the clip, over the scope clips, and also Doppler probes, all can be used, and most of the places it is available. What are about the rebleeding? What we have got, it is already seen that almost 15 to 20% patients have got the rebleeding if the patient has got bleeding from the ulcer, and highest rates of the rebleeding comes from 48 to 72 hours of the treatment. So for that matter, the message is you can try for the second time with endoscopic therapy, almost 50% success rate you can achieve. What is the role of the surgery? This is a big question because nowadays they feel that we don't consider surgery as an option for treatment. It is not like that. Of course, we have got the better medical management. We have got the advanced endoscopic equipment and also the visceral angiography. But progressively, there is diminishing role of the surgery, yes, but still it is the most definitive like intervention, and it is the final therapeutic option, especially in case of ulcer-related bleeding. So we have got still, of course, 5 to 10% of the rebleeding or mortality of these patients. Why? Because there is aging population, there is increasing comorbid conditions, and always GI bleed management is a teamwork. We should have a gastroenterologist, the ICU people, radiologist, and also the surgeon. Together, we should work and ultimately manage the patients with GI bleed. I was for a few days with the Mayo Clinic Worcester. What I noticed there, they have got the bleed team. 24 hours, particular day, any day, a gastroenterologist, surgeon, and the ICU personnel. Together, they will attend all the patients of upper GI bleed or lower GI bleed, and they will manage. And this study also clearly shows that if the bleeding is ultimately managed by the focus team, the results are always a better one. So active GI bleed, my friends, this is my last slide. With immediate assessment is important. Stabilize the patient with the hemodynamic status. Identify the source of the bleeding. Stop the active bleeding. Treat the underlying cause and also prevent the recurrent bleed. With this, I thank all of you for your kind attention. Thank you.
Thank you, Dr. Goswami.
Yeah.
So, for your nice talk, and I'll request our esteemed panelists to keep the questions. But before that, we'll go for an interesting survey which we have done. Dr. Akash, please. Dr. Akash is one of our. Dr. Akash, please share the slides. Dr. Akash is our consultant gastroenterology at Apollo Kolkata. He is DM hepatology from PGI Chandigarh, and before that he was faculty at SGPGI Lucknow.
Is it visible, sir? And am I audible?
Yeah.
Yeah.
Okay.
Audible.
Okay, so we'll just rush through some of the responses. We decided to conduct this survey to just have an idea about what the current practices are. We thought of initially directed more towards physicians. Uh, so we just conducted it for 2 weeks. We had 44 responses, quite less than what we had actually expected. It was mostly males, and the dominant group was between 30 to 40 years and 40 to 50 years. So, what's important is that most of the responses were actually from gastroenterologists and hepatologists. But what we wanted to focus was more on physicians and general practitioners, which only constituted about one third of the entire response. The responses primarily came from Eastern India. There were some contributions from outside, from Nepal, and the rest of it was distributed from the rest of the practices. Again, metropolitan cities, tier one cities, and medical colleges were the predominant respondents. So if we see the questions that we addressed, then the type of GI bleed that's normally faced, it was liver disease constituting around 70%. The next was, if there was a GI bleed present, what is the need of referral to a center with GI expertise? And we found quite a high number of patients, about high number of responses, around 34%, indicating that there is a need for referral, of which 85% said that the nearest referral center with equipped endoscopic facilities is less than 50 kilometers. But again, 11% said that it's near more than 200 kilometers. So there are areas where access to endoscopy still remains a challenge. What's interesting is that when we asked about what's the time needed for referral, 50% response was that it's only after failure of medical management. And another 13%, I think this is where we need to step in, that 13% referrals that's around would be only without resuscitation. So that's where we need to perhaps change practices a little bit. The first line management in patients with GI bleed, mostly it was IV fluids, around 45%, combination of IV fluids, blood products, and medications, 40%, blood products itself, 22%, and medications, 28%. So coming to rice tube insertion, as we were discussing in the talk, 37% of the respondents agreed that rice tube insertion would be as a part of initial management in all cases. Antibiotics are always a controversy whether to administer in all cases, even with now data coming out in cirrhotic bleeds, whether in child A bleeds, we should give antibiotics or not. So 50% usage of antibiotics in all cases. Threshold for transfusion, 85% less than 7 grams and 10% between 7 to 10. In cases where there was varicose bleed, the respondents had proton pump inhibitors usage is 47.5%. Again, this is possibly the area where we may have a discussion upon about the risks of using proton pump inhibitors in known cases of varicose bleeds. Terlipressin is the commonest vasoactive drug of choice, 62.5%, octreotide around 22%. The choice of PPI administration, again, that was a part of the talk. The most commonest mode of usage is bolus followed by continuous infusion, which is followed by bolus 12-hour leave. And last was a continuous infusion, which was the third choice. Certain gray zones that were there, as we discussed, that about the use of tranexamic acid, which is still carried out in 19% of the cases. We could not stratify by whether it's varicose or non-varicose. Access to SB tube has been an issue with very limited access at major places. It's only available, and the respondents said in 27.8% of the cases. And this is actually the reality of today, that access to SB tube has become a problem. The last one was mode of terlipressin usage. We are very much used to using terlipressin as infusions for HRS, but almost more than one third have indicated towards using terlipressin as infusion for GI bleeds. So I'm not aware of a lot of data about terlipressin infusion for varicose bleed, but this again is something that we can focus into. So that was about the responses from this short survey. We look forward to getting more responses so that we can have a more robust data that comes out of it. Thank you, everyone.
Thank you, Dr. Akash. So this is the idea of Dr. Akash and Professor Chawla. They want that we should do this survey where we can do some changes in the practice. But the bad part, I think, can say that it is mostly confined to the gastroenterologist and hepatologist. So I will request Dr. Goswami, all our esteemed speakers, panelists, and as well as Sir Chawla sir as being the chief editorial board, to if we can extend this survey to the more common peoples, this can be a good article also. And Akash is interested to write this as a survey to be a one of the publications. And if we can do for another 7 days, we can get at least 150 to 200 response will be good data. Chawla sir, any suggestion?
Yeah, I think it's a very good presentation that Akash has done. Very good survey. And I think we could also derive some research projects out of this.
Yes.
Bolus early present for control of bleed versus continuous. How does it work? And
Yes, sir.
we have very good suggestions. And I think you carry on with this more. And the focus has to be on physicians now. The gastroenterologists and hepatologists know well about it. But just one point, patient with ulcer bleed and cirrhosis, you need to give antibiotics there, or it's only varicose? Maybe BD would be able to answer that for the general public.
The point is, in case of ulcer bleed, there is theoretically no question of any antibiotic role. But in varicose bleed, already established different studies clearly showed that there is infection, and out of this infection, the chance of to stop the bleeding is difficult, and rebleeding chance is also is very, very common. So it is established that we should use the antibiotic in case of varicose bleed. In case of ulcer bleed, I don't think that there is any established guideline to use the antibiotic.
I think this can be a research topic again.
Yeah.
What do you say?
Yeah, definitely it is.
Ashok?
Yes, sir. We got good ideas now.
Yeah.
This is wonderful.
And another point I wanted to talk about, I mentioned also about the tranexamic acid. Earlier, yes, there were some studies, very small studies showing that it may be helpful one. But later on, all the studies clearly showed that there is no role of tranexamic acid. That's why I have given the slide here. So the physicians, they should know that there is no role at all that we can use or we should use the tranexamic acid in case of upper GI bleed. Or even
overall, very good presentations, both by Dr. B.D. Goswami and Akash. Excellent budding Akash. Good to see you.
Thank you, sir.
Yeah.
Madhumita wants to ask something.
Good evening, all. So, Dr. Goswami, the question is for you because this is a forum in which we have to tell primary practitioners about how to approach variceal bleeding. Sir, one clear message is, of course, regarding packed red blood cells, which you showed. But many a times we get referred cases who have been pumped with a lot of fresh frozen plasma. They have been given cryoprecipitate. So, what message would you like to communicate to primary care providers?
Now, point is, all the cases we don't need for these all these advanced medications or phase frozen plasma and all. Only limited areas where some patient may need it. But point is, if the patient has got variceal bleed and the area the patient is coming from, in that area, suppose there is no better options, facilities of endoscopy and all, or gastroenterology experts, I think those patients, they should be immediately referred to a higher center where we have got the facilities. Because already I have mentioned that mortality at the first go itself is almost 50%. So my message is, if it is capable of the controlling the bleeding, they have got the facilities of higher endoscopic role, then they should continue it. Otherwise, they should refer the patient, send the patient as early as possible. And before that, probably it will be better one if they push one bolus dose of terlipressin, 2 milligram bolus dose, they can push it and send the patient with a IV drip to a higher medical center. Sir, Chawla sir or Akash, your comment, please.
I agree what you've said. Fully agree. And the question of fresh frozen plasma, I think the message should go that all patients do not require fresh frozen plasma in cirrhosis.
Sir, I agree completely. In fact, I will add to that. The Boveno 7 has actually recommended against giving fresh frozen plasma because it is associated with worse outcomes. So only in a very, very selected patient where despite all other measures, the bleeding continues, only in that situation, after really discussing, we should give. Otherwise, actually, we will cause more harm to the patient than benefit.
Good evening, Akash sir. I totally agree. So the clear message is we should not try prohemostatic, prophylactic correction before the endoscopy. So the treatment is portal pressure reduction and not correcting an INR or platelet count. And you don't need to give prophylactic platelets before doing EVL. You don't need prophylactic platelets or FFP to inject glue. So this message should be very clear. Thank you.
Yeah. So in fact, if you read the latest guidelines of EASL, was fortunately one of the panel members for that on coagulation. So what Madhumita said is so true that we should not give any empirical correction before any band ligation or any procedures. Remember, this is applicable to all our OPD patients or indoor patients. This is not true for patients who are in ICU, who are infected, who have renal dysfunction. There, the rules may be different. So there, on a case-to-case basis, individualized decision has to be taken place. But for most of our patients, and especially for physicians, the run-of-the-mill cases, there, these rules are 100% applicable. People always used to say that there will be medical legal problems if we don't give, because INR is deranged and we have not corrected. But now, because the guidelines say that you should not be giving, if you give, there can be medical legal problems. So I think even that thing is now eliminated. So we should not be now fearful of these aspects.
Akash sir,
I must congratulate you. Fantastic presentation.
Thank you, sir. So, just on that note, since we talked about the Boveno discussion, there were some suggestions this time in Boveno that we can actually start avoiding antibiotics for child A. So it was not a very strong suggestion that if somebody with child A is coming with a GI bleed, to avoid antibiotics. So would it be translatable to clinical practice? Very difficult to design trials to, in child A populations.
Yeah. So, I mean, even if you look at the studies where antibiotics were not given in the previous era, the median survival would be around 5 years in a childless cirrhotic with a variceal bleed. So anyways, the mortality is low, and very rarely we see childless cirrhotic with bleed developing sepsis and multi-organ failure. So I think the evidence will be difficult to generate, but I'm sure it can be generated. As a clinical practice, personally, in a child A5, I don't give. But if it is A6, I give. But that is my personal practice. I cannot ask others to follow that.
I agree with Akash. Yes, very rarely a child A cirrhotic will bleed. Very rarely. So I don't think that we should go for antibiotic therapy on this patient. I personally don't think it.
Thank you, sir. Dr. Mamoon, any ideas from your side? Someone has asked about what is the target of hemoglobin in patients of COD with bleed, coronary artery disease.
Well, what we do is we usually keep it below 9 milligram per DL and try to maintain there in a patient with a history of bleed. Since otherwise it is expected that if it is overcorrected, then the risk of rebleed is raised. I don't know what you will suggest.
I also feel that in CAD cases, probably it is better to maintain the hemoglobin level at 9 or 10. That should be the idea about what we call.
But I have two queries to the experts. One is the use of medical management in active varicose bleed. Do we need to exclude underlying ischemic heart disease in every patient? And if so, then how? And the second question is when to adopt for prophylactic EVL. Can we do it without a history of bleed? Because say in a place like Dhaka city, where you may need 2 to 3 hours to travel a distance of 1 to 2 kilometers, and if you have a bleed, in a high traffic time, you may be placed in a very good city center, and you may be very affluent, can afford any treatment, but you may not be able to reach the center in time. So I have experienced two recent experiences I would like to share. One patient suffered from a stroke, ischemic stroke, after we administered, this vasoactive, this talipress in the patient, and subsequently, what our internal discussion will only identify the drug maybe. And second case is a patient who we did not, ban ligate, did bleed the day before he was supposed to fly for liver transplantation, and had to spend in an ICU for more than a month. And when he went for transplantation, in a very poorer shape, I say. So these are real life challenges in a third world setting like us. So what will be our approach in such cases? Thank you.
No, if the patient has got cirrhotic, patient is cirrhotic, and already we have shown almost child C cirrhotic 50% will bleed and 50% mortality. So high mortality. So during the baseline, always we should do endoscopy in patients with cirrhosis. So in baseline endoscopy, if you see that the patient has got large varices, I personally feel that we should ligate the patient. There should not be any question about that. What, sir, Chawla sir, what is your opinion, sir?
BD, I'm personally against prophylactic banding, even if the varices are large, especially in patients who are child C or late child B, because in case patient hasn't bled, and in case an esophageal ulcer post band ligation occurs and he bleeds, then it becomes a little inexcusable. So that's my personal opinion. So I won't prefer banding patients with child C or late child B. But certainly variable opinions are there. Beta blockers would be my first choice.
So there is one more question for our panelist, Dr. Abhigant. So one patient of CAD is an antiplatelets and he is having small bowel bleed intermittently. So what is your way forward?
For coronary artery disease patient, if he is actively bleeding and he is on to a secondary actively bleeding, he is on prophylactic antiplatelet agent for secondary prophylaxis, then we have to stop aspirin as well as clopidogrel. Both are. But if a patient is on primary prophylaxis for coronary artery disease, he should continue aspirin and stop clopidogrel or clopidogrel. And it should be started as early as possible within 7 days.
Okay, thank you. Sir, now we'll go to our case-based presentation. This will be done by Dr. Pukras, and his mentor is Dr. Girispati. Dr. Pukras, please start.
Good evening to all present. I'd like to thank Acharya sir, Chawla sir, and all other stalwarts. So glad for this opportunity, and especially to Girish sir and Ashok sir for their case, for their help in this case. To begin with, our first case is a 37-year-old female who presented to our emergency late at night around 10:15 with 2 episodes of hematemesis and bleeding with clots and in large amount, and along with passage of melanic stools which happened 4 times through the day, with no history of pain or no postural symptoms. She had received IV fluids at the local medical center 2 hours before and was referred. At admission, her blood pressure was 102 by 74 millimeters of mercury, and the pulse rate and tachycardia pulse rate of 118 per minute. On further probing of history, the patient was symptomatic since 12 hours, and hematemesis was preceded by epigastric pain with postprandial exacerbation, non-radiating, no postural syncopal episode or loss of consciousness. She had no history of jaundice, no history of alcohol binge drinking, no history of severe retching or any abdominal surgery. She gave history of polyarthritis and analgesic dependence since the last 2 years. Now, is this history enough for us to come to a diagnosis, or are we missing something with this history? On further probing, we found out that her polyarthritis was not evaluated completely. She was frequently on NSAIDs and suspectedly also took DMARDs used for the pain. She had no history of diabetes, hypertension, or any coronary artery disease, and was not on any blood thinner drugs with no similar past history. On examination, in the general examination, as noted earlier, her blood pressure was 102 by 74 millimeters of mercury. She had tachycardia with a pulse rate of 112 per minute, and a respiratory rate was around 20. She had pallor but no icterus, and she had bilateral joint pain, especially of the small joints, with pain, redness, and swelling, and sparing of the axial joints, along with swan neck deformity noted. Her abdominal examination was insignificant, with soft, non-tender, non-rigid, no rigidity or guarding. Liver and spleen also was not enlarged, and bowel sounds were around 20 per minute. We admitted her with the provisional diagnosis of acute upper GI bleed, with the likely source being a duodenal or a peptic, and a likely etiology being a NSAID-induced ulcer, with the slight abdominal pain being ulcer-related, along with a comorbidity of symmetric polyarthritis likely to be rheumatoid arthritis. Her initial investigations showed a hemoglobin of 6.7 grams per deciliter, with a normal leukocyte count and a platelet count, along with normal MCV and MCHC and a PCV. Her blood urine nitrogen was slightly elevated 28, but creatinine was 0.94, and INR being normal. Her initial ABG showed a lactate of 2.3. And we also had a RA factor and anti-CCP antibodies present, with ESR being 58 and CRP being 3.28. So in this case of acute UGI bleed, we planned for the further management by calculating her Blatchford score, which came out to be 15, as her systolic blood pressure was between 100 to 110. She had blood urine nitrogen slightly elevated. She had hemoglobin, which was on the lower side, less than 10 grams, and tachycardia along with melena. So what next? How do we manage this patient? On initial presentation, the primary goal is only to resuscitate this patient with a door to needle time of 20 minutes, as our emergency GR had started IV fluids with 2 wide bore IV cannulas. The next step was stabilization for this patient. We started her on IV bolus PPI, followed by PPI infusion, covered her with an IV antibiotic, planned for a PRBC transfusion with close monitoring of vitals, and kept her NPO and shifted her to a high dependency unit. This was late at night, and the door to scope time, which we targeted, was around 12 hours. We shifted her to the scopy room at around 11:15 in the morning. Her morning parameters were of hemoglobin of 7.8. Her blood pressure was around 110 by 70, and her tachycardia settled with her pulse rate being around 87. While we did the endoscopy, what we found was a prepyloric antral ulcer of size 8 by 8 millimeter with a visible vessel noted over the base, which we classified as Forest 2A. We covered this ulcer with dual endotherapy and did a gold probe coagulation along with multiple aliquots of adrenaline, which were injected along all 4 quadrants, and good hemostasis was achieved. During the hospital course, this patient was continued on PPI infusion and supportive management for 3 days. We advised nutrition after the endotherapy of 4 hours, which was a total NPO period of around 18 to 20 hours. However, is it sufficient enough, or is more time required for being NPO? Her daily hemoglobin was monitored and no drop was noted. We kept her in the HDU for 2 days, and daily vitals and bowel sound checkup was done. No increase in heart rate or bowel sounds was noted. But then again, should we assess anything more? After 72 hours, we assessed the patient again and did a relook at upper GI endoscopy, showing a Forest 3 ulcer, and we advised her on oral PPI twice daily. We transferred this patient to immunology department for her management of rheumatoid arthritis. We stratified this patient for rebleed with a Rockall score coming to be only of 3, with age less than 60, no coexisting illness, a peptic ulcer erosive disease, and the endoscopy stigmata being present. What we took as learning points from this case is that resuscitation is the key, and stabilization, optimization, and risk stratification is what forms the core of the management. We should never rush for immediate endoscopy. And pharmacotherapy with PPI definitely has a role, And dual endotherapy is preferred if stigmata of bleeding is present. We can consider up to Forest 2B patients to be preferred for dual endotherapy. And blood transfusion is usually indicated only if hemoglobin is less than 7 gram per deciliter. Coming on to the second case, which was a bit more complicated than this, we had a 65-year-old male who was a diabetic who presented with hematemesis, melena, hypotension, and grade 1 to 2 hepatic encephalopathy and lactic acidosis on his ABG. He had severe anemia with hemoglobin of 6 grams. He had tachycardia, pulse rate 120, and hypotension with blood pressure on 90/60. We evaluated and he was diagnosed to have portal hypertension with grade 3 esophageal varices. However, no RCS was present per se. We confirmed the diagnosis of ACLF with acute enveloping hepatitis E viral infection and the background CLT component being labeled to NASH. He had ascites, he had jaundice, he had HE, and CTP was 12, child C with MELD of 28. Initially, when this patient came to us, the first step we did an endoscopy and we found to have varices for which we did an EVL. However, after discharge, this patient had a rebleed after 15 days. He was in the periphery and managed with a Sengstaken black mode tube in the periphery and was referred from the peripheral center. After coming to our center again, an endoscopy was done after removal of the SV tube after 14 hours. And as we could see that there was presence of rebleed again. But what to do next now? His CTP is 12. The MELD score rose from 28 to 31. Clinical symptomology at this time of the presentation to our center was that melena was continuing. There were intermittent syncopal episodes and cold extremities. And on examination, vital signs were deteriorating with tachycardia increasing and the blood pressure decreasing. On per abdomen examination, there was increasing in the bowel sounds. His lab presentation at that time was hemoglobin of 8.3, TLC slightly elevated around 11,000, platelet count on lower side 19,000 with high INR of 2.49, elevated bilirubin of 18.4 and high AST of 226. Albumin is 1.8 and creatinine also on higher side 1.36 with elevated urea. This was the initial parameters just at the time of admission. However, how we managed this patient was we placed a self-expanding metallic esophageal stent, the Eladanus stent, to control the bleeding. As we could see on day 1, just before putting the Eladanus stent, his hemoglobin had dropped to 6.5. The AST had worsened to 398. Counts had started increasing to 19.5. Serum albumin showed slight improvement, but not much significant. Creatinine was improved. However, this patient on day 3 and day 7, after placing of the Eladanus stent, the hemoglobin showed definitive improvement to 8.2. However, the AST rose significantly from around 400 to 887, with creatinine also rising to 2.4. Further on day 7, the HP improved further with 9.6, but AST worsened and reached approximately 1000, and creatinine also shot up to 2.52. In this, with multiple complications noted, what we noticed was that the index bleed, which was managed with EVL, had a rebleed after 2 weeks, managed in the periphery with the SV tube. And after coming to our center, we did an endoscopy after 14 hours, which showed an acute variceal bleed or a post-EVL ulcer bleed, which could not be seen per se because of the clotting there. But there was also development of ischemic hepatitis in our center with worsening of AST seen. CTP score of 12 was seen, but the MELD had worsened from 28 to 31. We placed the DAN-SLF stent to control the bleeding. This patient underwent a live donor liver transplant on day 6, and this patient survived. But we had a lot of learning points to take from this case. To begin with, ACLF has a high chance of post-EVL ulcer bleed. An initial stabilization followed by early referral is key, which is how this patient could be saved. TIPS is not a modality with liver failure, especially with rising MELD and presence of HE. And the DAN-SLF stent could be a better option in such cases to control rebleed. As again seen, since the patient condition deteriorated, an early liver transplant may salvage the bleed of liver failure, and immediate prompt control of AVB and hemodynamic resuscitation with timely endotherapy is the key. Thank you.
Thank you, Dr. Pukras. I request our all panelists and retail boards, both the cases, very interesting. One is more challenging at a tertiary center, and another one is, can say at the primary level, where we can see and manage. So both the cases have a food for thought. So we need opinion and questions from everyone. It is open for discussion. And also I request Professor Akash Shukla to take over the audience questions also. Sir, this is the challenge patient about that.
Yes. Akash is trying to comment. So Akash, why don't you start?
Akash?
Sir, I'm on the road. That's why I wrote it as a message. So it's like only thing is that the tips can still be tried. I think those tips meld cutoffs are applicable for in non-rescue tips. I think we are getting data out that even in advanced liver failure, if it's using as a rescue therapy, then in such cases of GI bleed, tips is not a complete contraindication in advanced liver failure.
Yes. So we completely agree. So these cutoff values are for erective tips for refractory ascites. In bleeds, they are not. But of course, there are certain contraindications. Like if the lactates are very high, CTP score is 14 or 15. So those can be considered as contraindications, or where the patient is already in refractory encephalopathy. So those will be considered as contraindications to doing tips. Otherwise, for majority of the cases, tips is not. These cutoffs are not there. But of course, we have to understand the risk and the expertise that is available when we are planning tips for these patients.
Sir, my concern is, sir, in case of post-EVL ulcer bleed, where the facility is not available to feed the Danish elastin, whether should we go for the endoscopic glue injection below the ulcer base, and what is the role of octreotide and PPI and sucralfate, whether they should be given, that is for physician level, or there is anything to do at physician level?
So I think extremely important questions which you have raised. So basically, when you have a patient with a post-EVL ulcer bleed, as you very rightly said, if it is refractory, we can try the Dennis stent, and it is not available at most of the places. So, but what I would suggest is, because it does not require an endoscope to put, those who have the facility of a fluoroscopy, they can actually keep this stent. That is one of the advantages of this stent. And as you very rightly said, the other options would be to go put an endoscope and inject the glue or a sclerosant in the varix below the ulcer, because that is one of the most likely afferents from where the blood bleeding is taking place. We can have other options also. You can give a mechanical tamponade. You can remember that medical therapy is not going to work in these patients. So these will require interventions, otherwise they can bleed massively. And we can put in self-expanding, fully covered metal stents also in such cases in emergency. We can give vasoconstrictors, but again, the efficacy is dubious. So we can try terlipressin or somatostatin in these patients, but they may or may not work. What I'll suggest is, if you really do not have any accessories and you're in an emergency, if the glue is not working and other things are not working, you do not have Dennis stent. I have seen 1 or 2 times people inflating Achilles dilators, the Rigiflex dilator, and use that for achieving tamponade, and that has also sometimes worked. So these are some of the out-of-the-box solutions which you can try. But again, these are all to buy time. This Rigiflex and all, so that you can do a more definitive procedure. Ultimately, we have to address the portal hypertension. Unless that is addressed, these complications can keep on happening.
And so my another concern is, compared to terlipressin and octreotide, what Goswami sir has already told, there is very high risk of ischemia, and also there is gangrene and necrosis and ischemic heart attack and also stroke. So why should not we look for octreotide in place of terlipressin? Whether there is a head-to-head trial which prevent which is better, and what is the role of combination of octreotide and terlipressin? Whether there are any studies?
So I think that is why, from the reason for why most guidelines prescribed terlipressin was because there was an RCT which showed that there was a survival benefit when people used terlipressin. But that was a single study, and other studies have not really been replicated. And as you very rightly said, there are complications with terlipressin.
Yes.
And therefore, if you look at the recent guidelines, they do not specify which vasoconstrictor. So any of the three vasoconstrictors, terlipressin, somatostatin, or octreotide can be used. If you look at the cost-benefit ratio, there somatostatin actually comes out to be the cheapest, and therefore my personal preference is somatostatin because of the cost-benefit ratio, and we need more data as to which whether there is really a terlipressin is superior to the others or not. As you very rightly said, then there's lack of data on head-to-head trials, and that is why terlipressin for many years did not get a US FDA approval for this indication or for HRS. Now only they have got US FDA approval, that too for HRS. So yes, this is true, and complications are there with terlipressin, especially ischemic patients with ischemic heart disease, elderly patients, patients with peripheral vascular diseases. You can get complications, and therefore it has to be used with caution in these patients. And a somatostatin would maybe a safer choice, or octreotide also for maybe a safer choice.
Dr. Mamun, one more, because it is for the primary care physicians. A person comes with a bleed, how a physician can know that is it varicose or non-varicose, and how they can strategize the approach in a simple way. I think Dr. Mamun is driving, so I will ask our esteemed editorial board also is here. Dr. Vikas.
Dr. Ashok, can I answer this question?
Let our editorial board. Dr. Vikas. Okay, so I think we have Dr. Charles. So, Dr. Chetan. Okay, please, Dr. Girish. Sorry.
Yeah, I feel the ulcer bleed usually there is a history of some insult is there, might be drug induced, and also it is usually associated with pain abdomen. But varicose bleed usually not associated with pain abdomen. Rather, varicose bleed usually occurs following heavy means severe history of chronic liver disease, or there is history of alcohol wine drinking. So pain abdomen is the pertinent feature which usually gives a clue that possibly patient is having ulcer related bleed.
Thank you. I think please, Dr. Abhigant. Yeah, please.
One thing I will like to add, if there is a splenomegaly, there is more chance of variceal bleeding, and it can be simply identified by abdominal examination. So if a patient with splenomegaly or palpable spleen with GI bleed, we should think about variceal.
Dr. Abhigant, you are not audible. Anyway, we are getting. So you are getting some echo because of two devices because simultaneously. So I think we are now listening to Professor Subra sir, Professor Acharya sir for the just concluding remarks. Then I'll request Dr. Akash Shukla to announce the next session. Then we'll close. Dr. Acharya sir, please. Okay, I think it is too late now, so we have to close. Dr. Akash, can you give the final?
Yeah, so I'm very happy that this was the third consecutive session, and we have received such large audience, and every day more and more people are getting associated and interested. And this is a fantastic endeavor where we are trying to reach the grassroots level doctors across the country. And now I think I'm very happy that this time we had international involvement with Dr. Professor Mamoon from Bangladesh joining in, I'm sure he will take it to the next level even in Bangladesh. So on that note, we have had all sessions predominantly focused on liver. So I think it's time now, Ashok, we should take a backseat and we should now start focusing on luminal gastroenterology, because that is a far bigger number of patients as compared to liver. So on that front, we'll address something extremely common in the next meeting, and that is gastroesophageal reflux disease, GERD, and we'll have Professor A.C. Anand giving a talk on that. So on that note, I think we end this meeting, and it's over to the local coordinators at all the centers across the country. And thank you, Ashok, and congratulations, Ashok, once again.
Thank you, everyone. So I think we can close the session.
Thank you, dear sir.
Bye.